Good afternoon, everybody. I'm Adrian Dix. I'm BC's Minister of Health. Joining me is Dr. Bonnie Henry, BC's Provincial Health Officer. We're today offering a greeting, and this greeting, but also this briefing on the territories of the Musqueam, the Squamish, of the Tsleil-Waututh First Nations. We are honored to be here on their lands. Today we're going to have the opportunity to talk about issues relating to COVID-19, to respiratory illness, to vaccination, and answer the questions that you have on a number of issues, I'm sure. You may have heard earlier today the BC Public Service employees will no longer be required to provide proof of vaccination against COVID-19. This decision was announced by the head of the Public Service, Shannon Salter, earlier today. And I would say that the decision was based, as all of you know, on the very high level of vaccination in the BC Public Service in the current state of the pandemic, and it reflects what a lot of employers are doing and overall the advice of public health. I should also say that the vaccine requirement in healthcare, in public healthcare, continues to be in place. It's based, of course, on a provincial health order. It continues, and it will continue. It reflects the fundamental need to protect the most vulnerable people, especially people in acute care and in long-term care, but many more in our province. So while changes are being made by employers in other workplaces, in healthcare, the vaccine requirement that provides protection that BC led on during an earlier stage of the pandemic will continue to be in place. As all of you know, tomorrow will mark the third anniversary of the declaration of a pandemic by the World Health Organization on March the 11th, 2020. That it has been a long 3 years. I think I would just reflect on all of those who have suffered loss in this period, all of those who've suffered loss directly from COVID-19, suffered loss in the public health emergency. It is the overdose public health emergency that was greatly impacted by the fact of COVID-19 in BC. All of those who have had health impacts and ongoing health impacts, or have a sense of loss for things that they were unable to do. But it's also a time to recognize all of the things that were done together by all people in BC, by nurses and doctors and health science professionals and healthcare workers, of course, but by people in every town, in every place in BC, in every region of BC, who took action not just to protect one another, but to support one another in difficult times, who reached out when people were isolated, who supported their family members, their friends, and often people they did not know, but found a way to do it. All the steps that were taken. This is a recognition, I think, this 3 years, of who we are as a community and who we are as a province. The record on COVID-19 of British Columbia compared to other jurisdictions is an excellent record, and I think people understand that. And we frequently describe these things in terms of how did the government do, or how did public health do. But truly, if it's the case that we have done well, in spite of all that we lost in this period, it's because of everyone listening to me and everyone else in BC who took the action to get vaccinated, to protect one another, who supported one another in the community. I do want to spend and take a particular moment, though, to acknowledge the work of healthcare workers in our province who I think have faced exceptional circumstances, 2 public health emergencies. And just to note how challenging it remains today, last night at midnight, at 11:59, there were 9,927 people admitted to public hospitals in BC, which by any standard is a very high number. In the last weeks, the most recently recorded weeks, we did more surgeries in the public healthcare system than we had ever done at this time of year before. In fact, almost 250 more surgeries than we did for the very same week in 2019. before the pandemic, in spite of the changes we had to make, more diagnostic procedures, delivering more care to more people. And that continues. The strain of 3 years of the pandemic has been exceptional, and our healthcare workers have done extraordinary work. This morning, I had the honor, a dear friend of our families, myself and my wife Renee, Sarajini Saklakar, Dr. Paul Warich, who's one of those healthcare workers, passed away, and we attended virtually a memorial service. He's gone back to Ontario and passed away. Dr. Warich was an outstanding scientist, an outstanding psychiatrist whose patients benefited enormously from his care and gift. And his care and gift, especially in the time of the pandemic, especially with the challenges people faced around mental health issues of special, and it symbolizes all the work that all the people do. And we think of Paul today, taken from us too young at 51 from cancer. All that he contributed in these last years of his life to make life better for the patients he served. And that's true of healthcare workers in long-term care and the people that kept our hospitals clean. And 3 years into this pandemic, let us raise our hands to all of them, recognize all of them, thank all of them for their work and their contribution. This continues to be, as all of you know, a very challenging time. With respect to COVID-19, yesterday there were 205 people positive for COVID-19 in hospitals across BC, and others were facing the challenge of it and other respiratory illnesses. And so we continue to deal with COVID-19, and we'll continue to do so. And it's my honor to introduce someone who has been with British Columbians through this last 3 years and continues to be on this issue, to talk about our approach to vaccinations this spring, which continues to focus on a fundamental principle, fundamental to issues of vaccination and their requirements, fundamental to when we receive vaccinations, which is vaccines that protect first those who are most vulnerable to COVID-19. My honor to introduce Dr. Bonnie Henry.
Thank you very much, and good afternoon, everybody. It is starting a little bit to feel like spring here in Vancouver and other parts of the province, and that is a welcome reminder to us that we are nearing the end of respiratory season, although we're not yet out of the woods. I want to thank everybody who stepped up and did get their vaccination, their booster dose for COVID in the fall, but also their influenza vaccination. It has made a tremendous difference on the impact that this respiratory season has had on our hospitals and our healthcare system and on our health in our communities. It has made a major difference. But COVID-19 is still with us, and we're still seeing higher levels than we saw for some time. And as expected, we're starting to see a bit of an increase in influenza B. And I think I talked about this a couple of times as we went into respiratory season. We tend to see a bit of a later surge often of influenza B, usually affecting younger people and can be spread within their families. We know that vaccine continues to offer protection and to protection against the influenza B strains as well. But we are, thankfully, other respiratory infections like RSV have continued to decline. So that is important and a good reminder that we need to remain vigilant in our efforts to protect ourselves, our loved ones, our communities, and our families. And this includes staying up to date on COVID vaccines. So where are we now with that? As many people are aware, the National Advisory Committee on Immunization did come out with a statement about recommendations about who needs to get a vaccine in the spring period. And we've had a lot of discussions of that at the national level with NACI, on our Special Advisory Committee, and we've looked with our Immunization Committee here in BC at our data on immunity, on infection, on illness, on who's ending up in hospital, to try and find that best place of where we can provide the maximum protection for those who need it in this coming months. So we will be offering a spring booster program, aligning pretty much with the guidance from the National Advisory Committee. So this means the focus will be on protecting people at highest risk of severe illness. And they are also the people we know that their immunity, the protection they get from vaccine or from combinations of vaccine and infection, tends to go down more quickly. It doesn't get as high in older people, and it tends to wane or decrease more quickly. So the focus will be on adults in our province who are 80 and over. And if you're an Indigenous person in the province, we've always made some compensation for understanding the risks for Indigenous people. So that'll be 70 and older for Indigenous people. Those are people who we know should get a booster in the coming months. We'll also be focusing on seniors and long-term care. And over this last 3 years, of course, we know that our seniors and elders in long-term care have really borne the brunt of this virus. And we know that their immunity is wanes more as well. Additionally, and this is where we've varied a little bit from the NACI recommendations, based on our data here. So we're suggesting that anybody 60 and over, or Indigenous people who are 50 and over, who have not yet had COVID-19, and that could be from a rapid test or having symptoms of COVID-19, they can consider getting a booster dose this spring. And so why do we say that? And why are we not saying go out and get it? There's a couple of reasons. We are learning a lot about the immune system, about the vaccinations, about the durability of protection, and about what we call hybrid immunity, so that protection that you get from having both vaccinations and in some cases infection on top of that. And the vaccines that we know that we have proven to provide good, strong protection, but it decreases over time, and it changes depending on the interval you've had between vaccines, how strong your immune system is, and whether you've had an infection recently. So I'll talk a little bit more about that in a minute. So for everybody who is recommended in the spring booster program, the dose should be at 6 months or more after you've had either your previous infection or your last dose. So that means, for the most part, we're going to be starting in April. And as you know, we wanted to make sure that seniors in long-term care had the best protection possible when COVID was increasing in the fall. So most of the long-term care homes, for example, started in October. And so we'll be looking at April as the time frame for starting this campaign. So for everybody else who's not in that category, our data here in the province, the seroprevalence data that we've reported on, and the data on severe illness and hospitalizations shows that having had a primary series, plus, really importantly, a booster, continues to provide strong protection. And having protection against infection goes down. And having protection against infection goes down quite a bit, but that protection against severe illness and hospitalization remains very high. And we know that giving an additional booster from some of the data from other countries and from here as well doesn't add a whole lot of protection. We also know that hospitalization, when we look at our data, what we see is there's a bit of a step up for people in their 60s, and that's why we've included that recommendation to consider the booster if you're 60 and older. It's a step up again at 70, but where we really see the increases, people over age 80, and you can look at the data on the BC CDC website and you see that people who are hospitalized and more severely affected by this virus continue to be our elders and seniors. So our seroprevalence data, so what that tells us, and that tells us that across the age spectrum, we have a really high level of immunity that's, for many people, a combination of immunity that they get from vaccination plus having been exposed to and infected with COVID-19. So what does that look like? If we look at the spectrum across the age groups, for people under age 50, as many as 80 to 90% of people have some combination of protection from both vaccination and infection. So that's good. And what we're learning as we're going through this whole thing globally is that level of protection, your immune system remembers that for a longer period of time. So why you might not, why you may still get infected, The second part of our immune system, and I've talked about this before, what we call the memory cells, the cell-mediated immunity. Our system is primed. So when you are exposed to the virus, it can rapidly ramp up and protect you from getting more severe illness, stop the virus from causing more infection cells. So that's, and that is something that most of us have here, particularly younger people. So that's why we're not saying right now that you need to have a dose, and why we're saying it's better to hold off and make sure that you're ready when we head into the fall. And so there's still many things that we don't yet know. The other thing that I'll say is when we talk about the immune system, it's not all or nothing. So we do see decreasing, but that doesn't mean we have no protection and that we're exposed to the virus again. What it means is that on average in the population, the risk of getting infected once you've been exposed may go down to half, but you still have really good protection. You still have better than we had before, and that buffer is global now. So we aren't seeing the major changes in the virus that we were seeing even a year ago. So we've had, for over a year now, Omicron and different variations of Omicron, and the virus is becoming less severe because globally we have that level of protection. But we're not sort of at the end of the pandemic yet. We're still emerging from that. So this spring program, I believe, is going to be, it's in response to what we're seeing right now with a relatively high level of COVID circulation and still some changes happening in the virus over time. I also think that as we go into the next respiratory season, so thinking ahead to the fall, we'll be in a very similar situation. We may have new vaccines. We may have new vaccines that are developed to respond to the changes in the virus that we're likely to see over the next few months. And I hope we'll have vaccines that maybe have influenza and COVID together. So those are the things that we'll be watching. We'll be watching our data here in BC and globally, and we'll be making recommendations as we head into the fall. The other things I want to say is, that we know that this protection is holding up now for about 8 months, and that's how long it's been since many people got their bivalent booster in the fall. And so we'll continue to watch that. We also know that vaccination, and there's increasing evidence of this, vaccination is in very good protection against the long-term effects of COVID or long COVID symptoms. And that's really important too. So this goes to a couple of other things, which will be no surprise to hear me say, that unvaccinated people remain significantly higher risk of getting COVID, of getting sick with COVID, of being hospitalized with COVID. And so I encourage anybody who has not yet received the vaccine to talk to a healthcare provider, talk to your pharmacist. It is not too late to get the protection that's going to help you for the years to come, because this virus is going to be with us for the foreseeable future. And on that note, we've also got more and more evidence from around the world and here in BC that the bivalent booster, so the one that we had in the fall, that started in the fall, that has both the original strain and the Omicron specific strains, does give you longer, better protection against what's happening right now, circulating right now. So if anybody has not yet had a bivalent booster, you should get that now as well. So you can get that from your pharmacist, from the public health clinic. You can go online and make an appointment today. And of course, we encourage anybody who's not yet been vaccinated, and we have vaccines now for people 6 months and older to get their booster now. Anybody else who's not in the category that I just talked about and really feels that they want to have a booster this spring, I encourage you to talk to your healthcare provider or the pharmacist about, and to go to the BC CDC website and to look at some of the information that I've just talked about and make a decision with your vaccine provider whether it's right for you or not. And you can also phone the call center and we can provide advice to you on that as well. So as always, we'll continue to monitor the data and look at risks and changes to the virus. And as I mentioned, this is still a pandemic response to address the data that shows us that older people have more waning of protection and less hybrid protection, and there is still a moderate risk of COVID that's circulating right now. As I said, we don't yet know what the rest of this year will bring, but as global immunity increases, there is less risk of a brand new virus to which we have no protection, but much more likely to have more variants of what we're seeing circulating now. And I believe we will need to have another dose as we head into next respiratory season, and that may over time turn into an annual booster or an annual dose that we'll have to have before respiratory season. Or in my more optimistic days, I hope that with our vaccine technology, we might get a pan-COVID vaccine within the next period of time, and maybe we'll only need to have a dose that will last us for longer than 5 or 10 years even. So that part is speculation. I don't know yet, and we keep learning about this virus, but that's what I think we're heading towards. I also want to take a moment to talk about treatments for COVID. So as we know, some of the monoclonal antibody treatments have not yet been shown to be effective with the Omicron variant, but Paxlovid continues to be a treatment that is available and that works and protects people at highest risk. It is not a panacea in that it is a challenging drug and it has many interactions with other common medications that people who are at higher risk of having severe illness are often on as well. So it is a discussion between a clinician and an individual who's at risk about receiving Paxlovid. And what we have in the province, we established early on in this pandemic, was the COVID Therapeutics Committee. And I have asked them to go back and relook as more evidence on the benefits of Paxlovid have been shown. And as we've gotten more information and more comfortable and confidence in using these medications, that we expand the availability. And I know in some provinces they've made it available for people 50 and above. I think where the evidence that I see shows is really it's for people over age 70, and that's the group that we see being hospitalized, that bump up in hospitalization, and older people. And I'm hopeful that they will be making it more available. As you know, you can receive it by prescription from your provider across the province, in pharmacies across the province, or you can call the 811 to receive advice about whether it's available for you. So we are, as of tomorrow, officially 3 years into the pandemic. And it has been a long and challenging time. And I know it has affected all of us across this province, across this country, and globally. And I also know that everybody in this province has sacrificed in ways big and small. We talked a lot about how the impacts of both the virus and the measures that we've put in place to deal with this virus have impacted our seniors and elders across this province. I also think a lot about young people who have gone through such a challenging time, at times in their lives when these milestones that mark changes and transitions have not been able to be celebrated in the same way. We have asked a lot of people in British Columbia, and I am so grateful to everyone who did their part to support and care for each other, including following public health advice and getting vaccinated as the best protection you have. And as I believe we are emerging, there is still change and there's still uncertainty to come. And we'll be here to try and give the best advice that we have. And on that note, I do know that spring break is coming up for a lot of people very soon. And I do want to remind people of the very basics of staying away from others if you're sick, particularly, if you're not feeling well, maybe skip that visit to somebody who's more at risk, like your elder grandparents or others. Covering your mouth when you cough is still important, and cleaning your hands regularly. These are things that we should be ingrained in us, and wearing a mask in those situations where you're in indoor spaces, you may be around people who are more at risk. But we are emerging, and I believe ever so slowly, thanks to everybody in this province. We are moving into the light, and I'll stop with that. So thank you very much, and we're happy to take your questions.
Good morning. Please press star 1 to introduce you. Press star 1 to ask questions. For media in the room, please find out the microphone provided. And please ensure the providers with their full name and address. Meeting will be limited to one question and one follow-up. We will be starting in the room today. We have anyone listening. Please go ahead.
Thank you for this. My name is Jennifer Maher from Vancouver, Canada. My question is for Minister Dix about the Ozempic medication. Back in January, we learned that British Columbia Health Ministry was investigating why U.S. citizens were filing nearly 10% of prescriptions in the province for this drug also used as a cardiovascular treatment. And my question is in French. Où en est l'enquête aujourd'hui?
Oui, c'est plutôt une enquête en permanence, parce qu'on regarde ces chiffres chaque semaine pour voir ce qui se passe. Ce qui est important avec Ozempic, c'est que les gens qui ont besoin d'Ozempic, et c'est un médicament de deuxième ligne pour eux, ont l'opportunité d'en avoir, n'est-ce pas? Ceux qui sont des diabètes en première ligne. Et je pense qu'on continue à regarder la situation qui est en baisse depuis quelque temps, du nombre des drogues données aux gens étrangers de la Colombie-Britannique. Et on va continuer de le faire, de nous assurer que nous ne jouons pas un rôle de fournisseur de cela de préférence. Et autrement dit, de faire en sorte que les gens de la Colombie-Britannique bénéficient et avoir accès à un médicament qui peut être important pour eux. Donc ça, c'est notre priorité. Je sais qu'Ozempic, c'est un médicament qui bénéficie de plus que de publicité. On ne peut pas voir un match de hockey, un match de foot, un match de quoi que ce soit, un film, sans voir de la publicité de cette entreprise multinationale en promouvant ce drogue. Mais il faut se rendre compte que ce drogue est présenté par prescription, par un médecin. Ce n'est pas quelque chose comme une voiture populaire. Ce n'est pas un Tesla, c'est une drogue. Et qu'ici en Colombie-Britannique, c'est la priorité. On va toujours donner priorité à ceux qui ont besoin à cause du fait qu'ils souffrent du type 2 de la diabète.
Merci pour votre réponse. Et quelles mesures sont prises par le ministère de la Santé pour éviter que les Américains, par exemple, viennent s'approvisionner ici? Oui,
mais on a un processus en permanence pour assurer que des prescriptions en Colombie-Britannique sont appropriées. On voit les statistiques. J'ai partagé ces statistiques pour faire un point important, que notre priorité, c'est des gens qui habitent la Colombie-Britannique et ça va continuer à être comme ça.
Any other questions on the room? Please go ahead.
Francis from Vancouver Southern Province. Minister Dix, if you don't mind, please. Can you please tell me what has changed that you are allowing people that are already being fired from their jobs to come back? What is the nurses, the doctors that they worked before in the medical field and refused the vaccine? They've been dismissed. So are you taking them back now? They can come back to work, or they're still dismissed?
So just to clarify, the public health orders, the provincial health officer orders for healthcare workers in our system remain in place. So that has not changed.
One question is Bill 36 that was passed. And can you just explain how it's going to affect the future of the doctors and nurses that are not going to get the vaccines that are coming, or the vaccine that's already here, how it's going to affect them if they don't want to continue taking shots for foreseeable future?
Bill 36 has nothing to do with it, zero, nothing. And so it just has nothing to do with it. You will note that the provincial health orders and the actions we've taken have taken place under the existing Health Professions Act. Nothing will change in that respect, although the process is made more clear in the legislation, but it's the same. I said very clearly, Dr. Henry has repeated, I repeated, the change today was for the public service, right? Not for the healthcare system. The requirement to be vaccinated continues in the healthcare system, and it will continue in the healthcare system. With respect to Bill 36, it has nothing to do with that. Some people have been promoting that view online, and they're not correct. So step back with Bill 36, a significant process and a review by an international expert named Harry King. Then an all-party review, myself, the Liberal critic, the Green Party critic, with a unanimous report that has been implemented here. In addition to that, thousands of people participated in public process, 47 and a half hours of legislative debate. And what it does is something that journalists have been long asking for, but members of the public as well, is it provides significantly more transparency and efficiency to the regulation of health professionals, which is well over 100,000 people. Right? So that's what Bill 36 does. It's not about, it makes no changes to those vaccination questions we put forward, and to suggest it does is just to be contrary to the truth.
You, Dr. Henry. Over the last 3 years of the anniversary being marked tomorrow, in hindsight, is there anything you would have done differently over those 3 years?
That's always the question. It's so challenging. I mean, we were talking at an immunization forum just the other day, the COVID task force meeting just the other day about, what are the things, I think as a global community, had we had a better support of China early on, being able to stop this before it became the global tragedy that it did, is something that I hope we don't lose sight of, given the geopolitical situation we're in now. I think when I think back about what we've done and how we've come through this, all of the challenges really were in being able to communicate changes in ways that people understood, and part of that is my failings of communication, and that's been the hardest part. Is how do you find that balance of doing just enough? And I talked about harms, and I know this virus has been so hard on some people in our population, and the measures that we put in place have been hard, and they're not the same people always that are affected. And how do we do? And I recognize the harms that both sides caused, and trying to find that right balance has been the burden that we've borne over this last 3 years. So I think, if anything, I wish I could have communicated why we are making some changes better.
Okay, the next question will go to the phones. Our first caller on the phone is Richard Sussman, the Williams. Please go ahead.
I'm having some problems with connectivity here, so I'm hoping that you can hear me.
Yes, we
Can you
can.
hear me, Dr. Henry?
Yes, we can.
Yeah, awesome. Thank you. 2 questions for you. It would be a COVID briefing that all the questions.
Only 2?
Just to start with. In terms of the general population long term, is the assumption now that there will be fall campaigns with a potential COVID flu shot together, and that will be the one time a year potentially that someone will receive a COVID shot? Is that the assumption you're working under? And I want to understand fundamentally why lift the mandate in the public sector, in essence, ending one of the remaining mandates and not the ongoing vaccine mandate in the healthcare system?
Sure. Okay, let me talk about the first one first. The short answer is we don't know yet. I think that's what we're probably in for this year. And, you know, I've talked about how the oscillations in what we're seeing in terms of infections and surges has been getting less and less as we have this buffer of immunity in the population. And the buffer of immunity protects those people whose immune system doesn't respond as well to vaccine, and it provides protection to those people who have not yet been vaccinated. But if they do get infected, they're much more likely to get hospitalized or get very severely ill. So for the next year, I think we're still in the transition where there's much that we don't yet know. That's what the spring booster is. We know that there are some people who are likely to benefit from it. Most of us are actually doing pretty okay right now as we're getting the data. And the challenge is we'd like to have the data ahead of time to know what to do, but it's generating new information as time goes on. So, you know, last week we only had 8 months and 2 weeks worth of information. Now we have 8 months and 3 weeks worth of information. And so that is changing still. So my best guess right now is that we're likely to have recommend a dose for everybody going into respiratory season, and I suspect we'll do it. And you know, this is me just using my best thinking right now, unless things change, and they have changed. That we'll likely do similar to what we do for influenza, where broadly recommended, but really focus on those people who need it most. So that's this year. What's going to happen in the following year? I hope we won't need to consider spring boosters, that we'll see the oscillations and the sort of settling into the respiratory, the seasonal pattern more clearly next year. And there's still a lot of work being done on vaccines with the sharing of both the brain trust around the world and the new technology that has been really rapidly advanced, and we understand a lot more now. So I can only speculate as far as, you know, what's happening in April and May, and then what I think my best guess for the fall this year. And then we'll go from there. And if there's major changes in between, then we'll try and address those as they arise. So the difference between you know, what's happened today in the Public Service Agency is the type of workplaces we're talking about. And you may recall a year ago and 2 years ago when we were talking about vaccine mandates. And it is a risk assessment done by employers about the risks in their settings, their employment settings. And the Public Service Agency, we have many conversations about the roles that people play, the protection of workers in their workplace. Many of them are public-facing workers, and they made the decision as employers to have this in place for employees across the Public Service Agency. And they've made the decision, and yes, I was involved in providing advice about risk now, given the high rates of immunization and given what we're seeing in terms of the population and the transmission of COVID. That decision was made by the Public Service Agency to remove those mandates. My responsibility and the responsibility of the Minister, but public health, and my advice applies to healthcare settings, to the public healthcare setting. And those provincial health officer orders remain in place because that is the highest risk setting, both for healthcare workers and for our patients and residents in our care. So those mandates remain in place as we are not yet through this respiratory season, and we're not yet out of that highest risk period for those most vulnerable people. And I just hold my hands up to my colleagues in healthcare across this province who have so banded together to do the best that they can for each other and for the people that we care for.
Do you have a follow-up?
Dr. I'm just trying to figure out on the nuance what you just said at the end there. Like, is there a chance that mandate will be lifted? My understanding was that the sense from you was that it would be permanent, that COVID-19 vaccines would permanently be added to healthcare workers professional contracts. So just on that, but also for Minister Dix, as we see respiratory illness season go down, we're still seeing in some rural communities emergency rooms having to close because of lack of staff. Are you worried about the long-term challenges in rural communities? That even as we get back up to high staffing levels, there are still areas like Merritt and others where they don't have enough staff to ensure the healthcare services for those communities.
Yeah, so the provincial health officer orders, I hope, at some point will be able to sunset. But yes, we are looking at, how important is it to have immunization and protection of healthcare workers, of each other, and in healthcare settings. So I don't expect that to be something that will change. And we're looking at what does that mean in terms of policies and regulations within the healthcare sector.
And just to be clear, Richard, I don't expect it to change either. I would say with respect to the challenges facing healthcare in BC and in all jurisdictions, if you spend any time looking at any jurisdiction in the world with the public healthcare system, you see some of the same challenges. We have, as I mentioned earlier, 9,927 people in hospital, admitted to hospital in BC, which is less than when I was here at the beginning of January, which is 10,226, which is about the height at that time. But still, by any standards, high in general during the pandemic in 20 and 21. And the first part of 22, we were seeing hospital census in the 9,500 range, but not in the 9,900 range. And that's a significant difference. And you think currently all the patients at St. Paul's Hospital are about 426. The difference between 95 and 9,927 is about that. So it's significant. We have dramatically and effectively, through human resources actions, increased the number of healthcare workers in BC. You've seen the results in primary care in the first month of what's happened as a result of the work we did with the doctors at BC on a new doctor agreement, on the new to practice doctors, the tripling of the practice ready assessment programs, the new spaces at UBC Medical School, the new medical school that will be becoming the Simon Fraser University. These are all steps that we continue to take equally for nurses, and importantly for nurses, steps to both retain nurses, because that is obviously critically important, but a significant increase in training spaces for nurses. For health sciences professionals, again, same increase in training spaces, increasing opportunities to ladder up. For ambulance paramedics as well, and you saw ambulance paramedics supporting our most recent collective agreement at 96%. And then healthcare workers, the extraordinary, historic really success of the HCAP program, which was put in place during the pandemic to provide more care in long-term care and in home care and home support. There are challenges in some smaller communities where the opening of a facility depends on a relatively small number of people. When we see, as we see in the healthcare system, continued higher levels of illness, which can have an impact. And when it is not safe to operate in a certain way, we can't operate in that way. But our plan in Merritt, just as our plan in Port Hardy and in other communities, is to take action to support those communities and to see that those problems, which have been occasional problems, but significant problems whenever they happen in communities, and they're certainly significant in Merritt. We see the same approach that we took, for example, in Clearwater. You'll remember last year, Richard, there was a lot of discussion on that through to September 2nd. There hasn't been a closure since September 2nd because we took systematic action in that community. In Port Hardy, the plan that we've put in place, a significant plan we put in place to support all of the three hospitals in that region are I think you're seeing already the impact of that, the opening of long-term care beds, the improvements of support for people dealing with addictions issues, the hiring of new staff, and the work that's going on there. So I think it's fundamental to provide healthcare in rural BC. These issues are coming, do come, and we've seen it now on a number of occasions in Merritt. And the Interior Health Authority is engaged to make sure that we have permanent solutions, not just short-term solutions, permanent solutions to ensure that when people need care wherever they live, whether it's in Merritt, whether it's in Clearwater, whether it's in Port Hardy, or whether it's in Vancouver or New Westminster or Prince George, that they have the health care that they need.
Next question is for Georgie. Yes, ma'am. Thanks. This is for Mr. Dix. The federal government is calling back 82 million in health funding, mostly related to diagnostic services, including about 23 million for BC. What action to this callback, and why is BC allowing these charges to patients? Thanks.
Well, it's quite the contrary of that. I do, I would say in the nicest possible way to the federal government that provincial government has taken about 100 actions on health human resources, and we need them to act in areas where they have significant jurisdiction to assist in the health human resources situation in immigration, where the progress is frequently glacial. I would say with respect to the Canada Health Act, since 2017, taken action again and again, and this is particularly true in diagnostic care. And British Columbia takes the process seriously. We report seriously on the results here, and the federal government enforces the Canada Health Act intermittently across the country. I would say with respect to diagnostic care, for example, because a significant part of this is MRIs. In 2017, the 16-17 fiscal year, we did 174,000 MRI exams in BC. What that meant was the development of a private sector, because the previous government pushed a two-tier system of diagnostic care. We've changed that with the most dramatic change, I think, we've ever seen here. We've gone from 174,000 a year to 300,000 a year. We've added MRI machines. Our MRI machines are full to use to their full extent. That is 24/7 in 9 cases in BC. It was only 1 before. And at least 19/7 in 19 cases. In addition, we've purchased some of those private MRI machines to support the public system and added MRI machines across the province. In addition to that, we've brought into force provisions of the Medicare Protection Act, some of which we were interrupted in putting into force by some restrictions in a court case we were dealing with with Canby Surgical Center. So we've taken actions on the law, we've taken actions on diagnostic care, taken actions on surgery. We've brought contracted healthcare workers back into the public system. There's no level of government in Canada, no province, including the federal government, that has taken so much action and made so much investment to make the public healthcare system work and to bring people back into the public system. We're really very, very proud of that record.
Yes, I do. Thank you. The minister says he wants provinces to ensure that patients are not being charged for healthcare services, in particular virtual care. What is BC doing to prevent these types of charges from private operators?
Enforcing the Medicare Protection Act, which we changed. We brought in provisions of the Medicare Protection Act by regulation. As you know, there's been some talk about some particular issues, the TELUS health situation, which I referred to the Medicare Medical Services Commission, is now the subject of court action. But more important than this, people have this discussion of, well, we should have rules to block certain things. We've expanded the access to public services. When you have, just so people understand, because we're talking about diagnostic care, when you only do 174,000 MRI exams, which the previous government had done, when you have 1/3 per capita the number of MRI exams in the Northern Health Authority as they had in Ontario, then what you're saying to people is that for a small amount of money, you can get an MRI done privately and then come back into the public system. So we've changed that by providing better service in the public system, by using our public health equipment more, by hiring and training more staff. That's the way to do it. And I'd say this to the federal government and everybody else. We believe and we know that especially in the case of diagnostic care, having a public system that does exactly what we've done, 240,000 more CT scans, 100 on an annualized basis. And in terms of MRI, scans, 126,000 more in a short period. That's how you do it. You deliver outstanding service in the public system, because that's what it's all about. People who are waiting for a diagnosis, getting access to the diagnosis. And I remind everyone to look at the facts on these questions. I hear people talk about hip and knee replacements. I hear them talk about diagnostics. We've gone from near the bottom of the country in these categories to near the top of the country by those very specific investments.
Next question is Minister. Please go ahead.
Hi there. This question is for Minister Dix. I'm acting on behalf of my colleague who's doing a story about a young woman who's diagnosed with cancer, and the doctor said to her before she started treatment that she should have a retrieval done because the treatment would impede her ability for affect her fertility. And the stuff for this is not covered at all through MSP. And I'm wondering, is there any way for someone to get that kind of financial assistance in a situation like this, where their fertility will be negated essentially by treatment to keep them alive?
Well, in terms of individual cases, I don't. As you know, Lisa talked specifically about them. I'm of course always interested and open to hearing people's experiences, positive and their struggles with the healthcare system. So I'd be happy to take a look at it. Those decisions are guided by health professionals, the decisions we make, including with respect to what's covered by the medical services plan. And as you know, and we've seen this in different areas that evolve. The first question I received was about access to the drug Ozempic, and the drug Ozempic changed with respect to access in December and in significant ways. So one can review these things. So these decisions are guided by the advice of medical professionals. And but obviously, if people have concerns to bring forward, I'd be happy to take a look at it.
Please, Adrian Dix.
So I guess I would just clarify, so you would suggest that someone in this situation, or this woman in particular, should go to the ministry and say, hey, would you reconsider my unique circumstances?
No, I think what it is if people have concerns, they should bring them forward. And every day that happens, right, is to bring them forward, and we can look at policy questions. But ultimately, the advice will be guided by medical professionals, as it should be, with respect to different treatments and different kinds of care. That is how the Medical Services Commission works, how the Ministry of Health works, how the Health Authority works in these matters. So I think probably, if I understood the case, you're talking about a set of treatment decisions and the policies that guide those treatment decisions. I'm saying people have issues to raise about that. They can raise them, and the changes do get made. I'm not saying they will in this case. Obviously, you have to look at the details. But what I am saying is those decisions and what's covered and what we do and how we, for example, triage issues is guided by health professionals, as it should be.
And next question is for Minister. Please go ahead.
Hi, Minister. Thanks for taking my question. On the issue of physicians who have signed on to the new payment model, are you happy, or what's your thoughts about the number who have, and about 50% still have not? So what does that say about whether the payment model is attractive, and also the number of new doctors receiving through the new practice incentives?
Well, I was trying to figure out how one could spin that for it to be anything other than a breathtaking success, but there was, and then I got your question, Katie. So I appreciate that, and I appreciate the way you phrased it, and it's good to respond to it. It's an exceptional success. I mean, more than 2,100 physicians in a fundamental change to the way we provide primary care in the province. So, a change that will benefit patients across the province. It's a phenomenal success so far. Remember, it's important to put in context what that is, because not all physicians were on fee-for-service prior to this. But of all those that practice what we call longitudinal primary care, about 48.7% of existing physicians have already signed on in the first month, which is a breathtaking success. Not all of the remainder were on fee-for-service, it should be understood. Secondly, we've added, I think, about 167 who were not billing in longitudinal family practice last year, which is in the first month an exceptional success when you look at the relative number of people practicing in communities, which would be in the 35, 36, 3,700 range, and the total number of primary care doctors who are 6,800. So it has been a breathtaking success so far. This is a transformation. People have been waiting for years for this to happen. 79, 78% of billings were on fee-for-service in BC last year. 78, 79%. We have the highest level of fee-for-service in the country. So this is a movement within a month that puts us from the most fee-for-service to the massive move to a new payment model, which is significant. So it's breathtaking, and the reason it's a positive thing, and the reason it's good for patients, and the reason we've seen so many doctors join already is because we worked on it together. And this was a joint initiative that we worked on together that recognizes the work that family doctors do in the community, reflects that in their compensation, but also reflects the type of work they do. We're asking family doctors, in addition to everything else, to train more new family doctors and to supervise more new family doctors. We have to recognize that in training. Finally, I'd say, because there's questions earlier about rural doctors, the same agreement has made significant improvements for that group of practitioners as well. So I just can't tell you how delighted I am about how it's gone. And that doesn't mean there aren't going to be challenges, because it's that fundamental a change that we've seen in a short period of time. There are going to be lots of challenges. There's going to be occasionally doctors for whom it doesn't work. Final thing I'd say, there are some doctors who are on group contracts now, and a lot of those may be moving over in the coming months. So it hasn't stopped going up. I think it was about 2,141 today, and I expect that number to continue to go up. And boy, it's a significant achievement. That isn't my achievement; it's the achievement of all those that worked on this, including the doctors of BC themselves.
Yes, the federal government, Minister Dix sent out sort of a letter to provinces yesterday reaffirming the commitment to publicly funded healthcare and announced the deductions for the provinces related to patient charges. He did mention that BC got a bit of a reimbursement. So what does that say about BC's efforts to remove some services that were, like MRIs from the private system? And also, if you can you give us an update on the injunction against telehealth?
With respect to the latter, it's a matter before the courts, and it's being worked out there. In terms of what it says, first of all, remember the whole issue of MRIs wasn't in these deductions prior to that. I think the steps that BC have taken on MRIs are well known everywhere. You talk to people on the street, people tell me that with the MRIs they now have at 3 a.m, how happy they are to get them, because it means they get their MRI sooner. And the fact that we've significantly increased the number of public MRIs. And this is what we understand, because there was a report a while ago that treated many of those public MRIs as if they weren't public MRIs, because radiologists got paid through group contracts on fee-for-service. They're all public MRIs. We've seen this very significant increase. We've purchased private MRIs. No jurisdiction has done more on this issue than BC, and we're going to continue to take it seriously and to take action to ensure that people get the service they deserve in the public system. And this was a major failing of the healthcare system prior to 2017 that we addressed and we're addressing, and we don't turn away from it. We're taking the action that's required. Because I think a lot of people think it's a legal question. You should stop people from doing things. I think we should provide outstanding service in the public system, and that's on MRIs, on CT scans, what we are absolutely committed to doing.
The next question is from Ron.
Oh, hi. My question is for Dr. And 3 years ago today, at your press conference, you announced that there were 7 new cases of COVID detected in a total of 39 positive cases in the province. I guess as you turn your mind back to 3 years ago today, and all the people that studied been through, did you have any sense that it would have been, society and all of us would have gone through so much over the intervening 3 years?
Yeah, really good question. I think about the pandemic in kind of three phases, and there was the pre-vaccination phase and the uncertainty phase, and the phase where we were didn't know what was going to happen. And in that phase, what you're talking about, I still had some hope, I guess, that we would be able to push this virus back into nature like we did with the SARS outbreak in 2003. By the summer of 2020, it became clear that that was not possible and that this was going to go on. And then I think of the vaccination phase as our sort of second phase of the virus, and having vaccines within a year was just amazing and a miracle. Didn't have enough soon enough, but that was a very challenging time too. And then this last year and a bit has really been the Omicron phase, where things really changed again. So, having spent a lot of my life in pandemic planning, mostly based on influenza, I had scenarios that we had thought through and ideas of how they might play out. And I think what has really shocked me, surprised me, I guess, is going through all these phases. We've gone through about every single scenario that we had imagined could happen. So I think, know relatively early on that we were going to have a period of great uncertainty, and we were looking at what was happening in China. We looked at what was happening in Italy and the terrible tragedies that happened there in places that got hit really early on and hadn't taken measures to try and protect, especially those who are most at risk. So I think I had a sense that we would have a period of time where we would all have to take some very drastic measures to protect those who were so much at risk. But as I mentioned earlier, finding that balance was so challenging, and going on for so long, and the scenarios changing so much was the hardest part about this, I think, and hard on everybody. And I absolutely recognize that we have all suffered through this, and it has affected us. And I talk a lot about it has exposed some inequities in our society. And if we think back to this time 3 years ago, how much we realized we depend not only on healthcare workers, but on grocery store workers, on people who work in pharmacies, the people that pick up our garbage, that these are important parts of our lives, and that these are workers who may not have been valued in the way that we needed to recognize them. And so if I think about the things that made a difference in addressing some of those inequities, I think about the fact that we have mandatory sick leave. And I talked way back in March of 2020 about telling people what we need you to do, and giving you the data saying why we need you to do it, but giving people the means and telling people to stay home when they're sick, when they can't feed their child, or they can't have no way of, they don't have any sick leave, they have no way of staying home without losing their job. So I think we've seen a lot in society that I hope, will continue to work together to address. I worry that we're forgetting already some of those things that are so important in our social connectedness, in our society. So that is something that we in public health are going to continue to advocate for and to focus on. Which is kind of a long answer, sorry.
Thank you. Yeah, by way of follow-up, I guess I'm wondering, it's still declared a pandemic, but World Health Organization can talk about it. But when do you think it will no longer be declared a pandemic? As a practical matter, what will happen when it's no longer declared as such? And I'm also wondering if you have any
if I have any.
place, whether it's as it relates to children. I know this is with the benefit of hindsight, but as we look forward to the legacy of COVID, there'll be some good and there will be some bad. Do you have something you wish you could do differently regarding restrictions?
When the pandemic phase and the emergency phase of the pandemic is over, and I think probably as we head into the summer, unless things change dramatically, we'll see that happen. And I hope that we'll be able to remove the public health emergency around the pandemic and start to, but that doesn't mean that COVID's gone and we don't have to do things anymore. It means that we're at a level of, the level of uncertainty has decreased and the changes are happening in a much more slowly and manageable way. So COVID is still going to be with us. SARS-CoV-2, this virus, is part of our lexicon now. It's part of our life. It's another vaccine preventable disease that we will have to pay attention to for the foreseeable future. So it is putting it in that context as we emerge. We're still not out of respiratory season, but I hope and I expect, given history, that end of March into April we will be. And then we look at, okay, well, where are we now? What are the things that we need to have in place? In terms of restrictions, some of the things that I'll turn it a little bit differently. We didn't do some of the lockdowns that were done in other jurisdictions. If you recall, even during the period of greatest uncertainty early on, we provided advice to people, but we tried to find the balance of going outside, knowing that that was a lower risk, finding ways that people could do these important social connections that we need in our lives in a way that protected those who are most at risk. We opened schools in June of 2020, and schools remained open. I think that was such an important thing. We know that young people need that safe environment, that structure in their lives, that the social interactions that come with schools, and having the measures that we had in place in schools. And again, I give credit to our committee, but to the superintendents and principals and teachers and families, school communities who really came together and recognized how important it was for children to be in those settings and to continue to learn through this pandemic. Those are the things that are really important, and that I think we did a really good job on. Some of the things that we may not remember is, we tried to keep as much open as possible, as safely as possible. And part of the strategy behind that was the COVID safety plans. And so COVID safety plans were what allowed us to do so much more on an ongoing basis. The time period, though, that was the most difficult for me, for all of us in terms of decision making, was really the Delta period. And that was in the fall, late summer of, I don't even know what year I'm in now, of 2021 and into the fall and winter of 2021, just before Omicron. So once we had vaccination, we started to see that dramatic decrease in illness, particularly in older people. Just how wonderful that was. And through that summer, we were in a place that I was hopeful, I think all of us were really hopeful, was in a place where we would be able to start getting back to more of the activities that we needed. And we took a cautious approach, and I think that was important, and I stand by that. But when Delta came, it was hitting young people. They were in emergency departments. These were people who were not yet vaccinated very often. It was such a difficult, it was a very severe disease in very many people, and particularly in the north and the interior, where we had to medevac hundreds of people in critical care, most of them with COVID, to places in the south. That was the hardest time, and we were all tired, and we were all tired of this. And I think, I can't remember whose quote it was, but I think it was Churchill's, when you're in the middle of hard, everything feels like failure. And I think that was a very challenging time. And again, I lift my hands up to communities who supported each other. And I think a lot about the communities in the north who had such a difficult time. Sorry. This has been such a challenging time for everybody. Talking with the communities in the north who banded together and supported each other through that period of time in particular. So, there's so many stories that we have lived through together in this last 3 years. And I think all of us have been changed by it and affected by it. Thank you.